So now turning to the results, first of all, there was a significant correlation between Corus CAD algorithm and plaque burden by both QCA as well as calcium scoring. So within the context of the study, we had 3 patient cohorts, and I will focus on the aggregate of these. But in terms of QCA-derived plaque burden out of the 1,100 patients, when we looked at the relationship between the score shown on the x-axis and the burden of disease as measured by QCA, you can see a significant correlation with an R value of 0.35, 0.39. In the subset of patients who had a calcium score, which was much smaller, about 79 patients, but even in these patients, you can see we did see a pretty wide range of calcification ranging from 0 to over almost 3,200 with a median of 270. And yet again, you can see a significant linear correlation between the score and the calcium score, and these were very similar in the 2 cohorts, the development and the validation cohort. Secondly, Corus CAD significantly predicted the positive calcium score patients in an ROC analysis. As you know, in an ROC analysis, you dichotomize the outcomes, it's positive versus negative, and then we looked at the performance of Corus CAD to predict the presence of positive calcium score. Again, based on the ROC analysis, we found that the area under the ROC curve was 0.92 in the overall cohort, which is quite good. And using the clinical cut point that was derived from the QCA analysis, looking at the cut point of 15, so this is the Corus CAD score of 15, if we use this cut point, then the sensitivity of the test in predicting a positive calcification was 90%, and the specificity was 88%, and you can see the similar numbers in the 2 independent cohorts.